Hello, this is Dr. Brian McDonough, and welcome to a special edition of Healing Healthcare. My guest really needs no introduction, but I'll introduce him anyway. He's Dr. Steve Permut. Dr. Permut is a physician, he's an attorney. He has created a residency program which trains young physicians. He has been a chief medical officer, he's worked in the insurance business, he's been the chairman of a major medical school department. He's been a delegate of the AMA. Pretty much in his career, he's done everything. Steve, thank you for joining us on the program. I really appreciate it.
Ryan, always a pleasure to be with you.
My question is, you pretty much have seen it all for the last 5 decades or so in healthcare. And we're at a point right now, which is probably, some say, a very pivotal time in healthcare. Hospitals right now are in a situation where they're dealing with the impact of COVID. People are stressed. They're overpaying nurses who are traveling. There's physicians and other people who are burning out. A lot's going on. Tell me where we are in your eyes in healthcare, and are we in trouble? Are we better than we've ever been? What's your perspective?
Yes.
We're in trouble and we're better than we've ever been. In other words, what you're saying is it's good and bad?
Right. Everything you've said is basically true. We're in trouble, but we're also in a better place than we've ever been. So, 100 years ago, we went through a pandemic. Philadelphia, where we're seated, was ground zero for the pandemic of 1918. We didn't learn a lot of things at the time of that pandemic. And when this pandemic hit, we were essentially at the same place where we were 100 years earlier. The one difference is that we had invested in science, and in an amazingly short period of time, we were able to come up with 3, 4, now 5 very effective vaccines against this virus. And as you know, of all of the infectious organisms that we have to deal with, viruses are the most difficult to treat. But yet, in a relatively short span of time, we had an effective vaccine that has dramatically reduced death and injury from this very communicable virus. And as we speak, there is another wave of a new variant of the Omicron virus that is tearing across the country. But thank goodness, people aren't getting tremendously sick. People who are fully vaccinated and boosted are not getting tremendously sick from this latest variant. So in that sense, we're in a good position.
There's so many things to unpack when we talk about healthcare and where we are and this pandemic. Healthcare, this has happened before, but health became very political with HIV. I remember it became very political now when we're talking about COVID. When politics gets meshed with medicine, is it a good thing, a bad thing? Is it just part of the normal process? What's your take on it?
The political situation we're currently in is just untenable. The thing is, though, that if you look at healthcare in this country, even though we do not have a single payer system, and I don't think we should have a single payer system, I would say in excess of 60 to 65% of US healthcare is paid for by the government. And the government is involved in funding the research that leads to the tremendous technologies that have allowed us to respond to COVID in such prompt fashion. The thing is that you can't get money out of the government without going through Congress, and that makes it very political.
You started in medicine, I would say probably mid 70s or so. That's probably when you got going. And obviously, at a very young man, you created a residency program when people weren't. I mean, to give a background for those who are listening or watching, I mean, he is an internist who then joins the fledgling field of family medicine and starts to provide total care and then starts a residency training young physicians. And that's all probably before you were in your mid 30s. I mean, probably maybe even younger. It was a different time. Tell me about that time.
Well, I mean, if you look back, I mean, we're looking back 45 years. I started a solo private practice in the inner city of Wilmington in a diverse community, which is where I wanted to practice. I ran a solo private practice with one employee. We saw the patients efficiently. We drew bloods there. We did flexible sigmoidoscopy there. We did originally rigid sigmoidoscopies there, but with just one employee and really minimal overhead. If you look at the national averages for the overhead for family medicine and most ambulatory practices, it's staggering. It's in excess of 60% overhead, between 3 to 5 full-time employees to support each full-time physician. And again, in 1975, I had one full-time employee with predominantly an accounting background who was able to support my practice. So the cost of practice has just gone off the charts. You can't mention that without saying that over literally the last 25 years, Medicare has not increased physician fees at all. You hear about some incremental increases, but then they do things like withholding 2% of all healthcare costs, and that reduces or erodes whatever minimal increase might have been created. And now for 2023, CMS, the group within the government that runs Medicare, is planning about a 5% decrease in physician fees. So there's been a tremendous increase in the overhead to run practices, but actually physician reimbursement has been stagnant. I think, a big part of the problem is that there isn't sufficient emphasis on primary care and focusing on the family physician, the general internist, the general pediatrician, in many cases, women's obstetrician gynecologist, to really coordinate care and be sure that care is as efficient as possible. But now you have a patient who goes into the emergency room with chest pain. A heart attack is ruled out, or maybe the patient even gets admitted for observation, and then instead of referring the patient back to their primary care physician, which they do, in addition to that, they refer the patient to a cardiologist. And then the patient follows up with the cardiologist, and the cardiologist feels obligated to do a battery of tests to be sure that the patient doesn't have heart disease, because that's their niche. And it's not a profit motive, it's that their responsibility is to be sure that any patient sent to them with the possibility of heart disease doesn't have heart disease. And that requires testing, and the testing is often very expensive. If the patient was just referred back to the patient's primary care physician, the primary care physician can put that patient's chest pain into some perspective of the patient's overall health. And maybe the patient does need to go to a cardiologist, or does need to have a stress test or an echocardiogram or whatever. But not every patient that comes out of the emergency room who went in with chest pain necessarily needs to see a cardiologist, and it would be much more efficient to let the primary care physician kind of call the shots in terms of where those referrals go.
It's interesting as you talk about this because you're an MD, JD. Uh, Early on and probably continuously, a lot of tests are ordered, a lot of decisions are made for fear of malpractice, for fear of lawyers getting involved. How much has the legal system impacted medicine from the time you started to where you are now? And has it been a good thing or a bad thing? Obviously, people should have someone to support them if something's done wrong to them. But has it gotten out of control?
Well, it is out of control, and some states have been able to get somewhat better level of control through legislation to limit frivolous lawsuits. But the problem is that the fear of a lawsuit and the fear of being second guessed if something goes wrong with the patient results in what we call defensive medicine. And that is the ordering of tests to kind of make the four corners of the chart look good if there ever is a lawsuit. But many of those tests, perhaps 20% of the cost of healthcare is going for defensive medicine. And when you're talking about a $3 trillion national healthcare budget, 20% is real money. And then the other thing that you have to remember, some people scratch their heads and say, well, it can't hurt to do too much testing. But in fact, every test has a risk associated with it and could lead to even further complications. So you really want to be razor sharp in terms of the tests that are ordered and the specialty referrals that are ordered. And that would be a way to really get control over healthcare costs in the United States. And again, around a primary care model.
So I started this podcast with the thought that after the pandemic, our system was overrun by people with quote unquote pre-existing conditions or the elderly. We can't do much against Father Time, but with pre-existing conditions, I thought after 30 years in primary care, are we really doing a good job? Because the diabetics, the hypertensives, the people who went and got drugs on the street, those who had social influencers of health impacting them, we weren't making much of an impact. Despite our best efforts, they had to come to our offices, they had to get care, and we had this big bureaucracy, which, as we've talked about for the last 50 years, it's built up. We now have hospitals overwhelmed with people with pre-existing conditions. It's even interesting, as we talk today, I was looking at it. If you look at the Johns Hopkins number, there's about 1.2 million people in the United States who have died of COVID. But in a typical month, the last 28 days, about 9,800 people have died, which if you break it down, it's about 140,000 deaths we will expect this year. And they're largely people either who haven't been vaccinated, who have pre-existing conditions, and who maybe haven't gotten the care they should. It seems to me we're failing because if we get to COVID-28 could bury us because we don't seem to be making the corrections, the changes. We're not getting out there. We're not helping. And so this concept of healing healthcare, how can we make a difference? I mean, is it a bigger system and physicians have no chance? Is there a way they can work through the system and make it better? Because it does seem to be from the days when you started, when you and one person could make a major difference, you now need an army of people to do the same darn thing.
Well, but Brian, you have to realize that a key part of the healthcare team is the patient. And we really need the buy-in from the patients to take care of themselves. In the case of COVID, to get vaccinated and boosted and to kind of follow the news for, where the surges are and what can be done to prevent serious disease from COVID. Now, to some extent, just because we didn't know what the effect of the vaccine would be, our assumption was that if you have a vaccine for something like chickenpox, you don't get chickenpox. But in fact, with a number of vaccines, and the annual flu vaccine is a good example, you may still get the flu, but you don't die from it. You don't get hospitalized from it. And the same thing is true with COVID. So, one of the key things around COVID is that the healthcare team, including the patient, have to come to an understanding of how important vaccination is. And we really need, we need key figures that people look up to buy into that and get vaccinated. The prior 2 days, 4 Philadelphia Phillies could not play baseball in Toronto because they refused to get vaccinated. What message does that send to young people in terms of the need to get vaccinated? I forget what team is going into Toronto today. They're worse than the Phillies. I think there are 10 players that young people in that market look up to. Well, if 10, I don't know, Kansas City Royals or whoever is the team going into Toronto tonight aren't getting vaccinated, why do I need to get vaccinated? So look at the message that some people that should be demonstrating good health practices are sending to young people who emulate them. Well, I think to some extent we do oversell what medicine can offer. And as you know, Brian, as you see patients, it's kind of a negotiation to get patients to buy in to the healthcare plan to improve their health or to control the diseases they have. Now, you take somebody and they have a high cholesterol, and you convince them to take a statin to bring their cholesterol down. The patient often feels that, well, now I can't get a heart attack or I can't get a stroke. When in fact, all we've done, or what we've done, it's not just what we've done, but we've done the ability to significantly reduce their chance of having a heart attack or a stroke, but we haven't eliminated their chance of having a heart attack or stroke. And so then, when they see somebody who runs every day and still gets a heart attack, their attitude may be, well, look at Joe Blow. He's been very, very active and he's still got a heart attack.
Right.
If I really don't want to jog every day, I don't want to jog every day, But getting back to, and I'll get to the EHR and electronic health record in a minute, but you talked about hypertension and diabetes. And, over the last 45 years that I've been in practice, the armamentarium that we have, the drugs, and for heart disease, the techniques that we have to address those problems are tremendous. But a big part of addressing those issues is lifestyle change by the patients. And that can often make the biggest impact, but is often the most difficult for patients to understand and to make the changes necessary. In terms of, go ahead.
I was going to say, full disclosure, Dr. Permut years ago was one of my teachers, and I had no chance competing with him on hypertensive medications when there were about 10. So I don't want to think about talking with you with the armamentarium we have now, because I think you recognized, even at that point, you recognized the importance of knowing the tools we have and using them. But also, I distinctly remember you were talking about how do you impact the person and impact their life. It isn't just a med, it's other aspects of care that are so important.
Right. In terms of electronic health records and the fact that patients have access to their health records, I think that that can be a very positive thing for patients who are motivated to check into that. So, now often the patients can see their lab results even before I've seen their lab results, and they can raise questions about, well, what do you think about this low calcium or this high low density lipoprotein, and what should I do about it? So I think for patients who are conscientious about their health care, that electronic health records will be very helpful. Also, the opportunity for the electronic health records to raise flags to alert the physicians of things that need to be addressed, whether it's immunizations that are lacking or follow-up blood tests or colonoscopies or whatever, the electronic health record, can provide the artificial intelligence, if you will, or assisted intelligence, I guess we call it now, to make that care better. On the other hand, there is so much for the physicians, there is so much information embedded in the electronic health record that it is a frequent cause of physician burnout, because you feel like you're spending probably 60% of your day clicking your life away to get information out of the electronic health record, or to put orders in, or in some cases to write patients letters about the results of their tests or work notes and things like that. And so in a lot of ways, the electronic health record, while providing more information on the patient to the physician, is creating additional burdens on the physician.
So let me take advantage of your experience, your years of seeing this, your experience with the AMA and on different boards and places where you've served as an administrator and educator, and you still see patients. What is our way out of this, or not necessarily out of this, but what's our best way to improve healthcare for our patients in the next 10 years?
Well, again, I think it's all around an emphasis on primary care and creating real partnerships between patients and their primary care physicians. I think that is the key thing. And if you can develop that good relationship and can motivate, or if the team process can motivate patients to make the lifestyle changes necessary and to take the medications necessary, I think that will improve the system, will improve healthcare, and can potentially lower costs.
So it kind of comes back to what you were doing almost 50 years ago.
Right.
A doctor with someone in the office working with their patient to make things better. It's the same core, I guess, attempt to improve healthcare that's there that would work.
Yeah, but the problem is that in that setting, medicine is basically a cottage industry. It's a place where all revenue minus expenses falls to the bottom line for the physician and the physician's staff. And this gets to a really fundamental problem. Now, fewer than 50% of physicians are in private practice. They are mostly employed by health systems, to some extent by health insurers. And the reason for that is they graduate from medical school, and then debt accrues during residency, so that they have so much debt that to invest in going into private practice is kind of a non-starter. And so what we're developing now is a huge healthcare task force that are employed by hospitals and don't necessarily have the setting in which they can do that cottage industry kind of small hometown practice uh, where outside corporate influences don't impact the way they practice.
You bring up an interesting point. Obviously, I mean, I'm a dual citizen, so I follow Ireland and the national health system. And then I look at that system where there's certain things that are great, but then I see, like, they call them trolleys, which is basically gurneys, but the trolleys are lined up outside of the hospital waiting to be seen. And the capitalist says, why isn't somebody out there just saying, for $10 or €10, whatever it is, I will see you and take care of you? And it doesn't happen. So you have one world, which is socialized medicine. Another world was just capitalistic, but it seems like third party payers and others are trying to extract what they can, running it like the automobile industry. Like, how do we get to the point where we're worried about patients again, because we're all patients, and providing the best care?
Well, I mean, you have to remember that in Ireland, there is a secondary system of private health care and private health insurance where the people who don't want to wait on those trolleys or for things that they can afford want to bypass the long lines and get the care when they want it.
Right.
Americans demand instant gratification. When they need something, they want it yesterday, and our system supports that, but at a tremendous cost to the nation.
One last question. Are you optimistic, pessimistic, just kind of meh, about the future of healthcare and our ability to heal healthcare and to make it better?
Well, I mean, one thing that we kind of skipped over is the educational debt. And that is a huge burden on young physicians. When I went to medical school, the total for my 4 years of tuition at Temple, mostly at Temple, was about $4,000. Students today graduate with $250,000 worth of debt. Their tuition is right around $250,000. Now that's an incredible debt load. And then what people don't realize is, some people say, well, how much does a physician make every year? Oh, 240,000. So they'll pay that debt off in a year, right? Wrong. I mean, first of all, it has to be paid off with after-tax dollars. Second of all, while it's being paid off, the physician has to live. They've postponed anywhere from 4 to 11 years of their earning capacity to get fully trained. And so they need to start having families and buy houses and cars and things like that. And so the added burden of educational debt really burdens them. But what I really want to say about that is we still have an incredible number of people that want to become physicians and who are becoming physicians knowing that they're going to assume that level of debt. So I'm optimistic because if the number of students we have are still so altruistic that they want to incur that level of debt, delay their earning capacity for that number of years to help people as physicians, how can you be anything but optimistic?
That's a great way to end this segment, because I think you're right. I think I look back on it. I went to Temple as well. $12,000, $15,000 debt. It seemed like a lot at the time, but we work with young doctors all the time. I know you do. And you are talking about the hundreds of thousands of dollars. And they're saying, I don't care. I just want to help other people. I want to do what I want to do. And they're willing to take that on. And if you have that energy, hopefully it will make a difference. One last question, then I lied. One last question. Could you provide medical school education at a reduced cost? I mean, is there any reason why I understand why, but is there any reason why it has to cost $250,000? I mean, could you realize big picture, this helps society more?
Um, it's not an easy question to answer. I mean, certainly a lot of it is large group learning, still a fair amount of lectures, but a lot of the education is done in small groups, and that requires faculty and resources and so forth. The other thing that you have to remember is that you really want people learning in a research environment, so that the students coming out don't just have the fixed knowledge that they graduate with, but have an appreciation for how medical knowledge is advanced. And that means that they should be in research at research universities, at medical schools that do research, and that is very costly.
Well, Dr. Steve Permut, it's been an honor to have you on the program to talk with you. I mean, your career has been amazing, and the fact that you maintain your optimism and you continue to think things will go well, I think, and you continue to practice, I think that says a lot about you, a lot about family medicine, a lot about healthcare. And for those who are watching, I appreciate your time and your input. It's been very fun. It's been fun to talk to you.
Good. Always a pleasure, Brian. Thanks for having me.
We'll talk to you the next time on
Great.
Healing Healthcare.
Take care.